The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Welcome to today's webinar, and thanks a lot for joining us. My name is Deanna Helsher, and I'm the Regional Dean of the UTHealth School of Public Health in Austin and Director of the Michael and Susan Dell Center for Healthy Living. Today's webinar is hosted by our center, and our center's vision is healthy children in a healthy world. And so you'll see some information on kids and COVID through this presentation. Before we get started, I have a few housekeeping announcements. One is this webinar is being recorded and will be archived along with the presentation slides on our website at msdcenter.org. The second thing is, if you have any questions during the presentation, please enter them into the questions chat box. We will have time for a Q&A at the end of the presentation. And so now I'm excited to announce our speakers, Drs. Joe McCormick and Susan Fisher-Hoch. Both Dr. McCormick and Dr. Fisher-Hoch are professors of epidemiology at the UTHealth School of Public Health in Brownsville and adjunct professor of medicine at the McGovern School of Medicine in Houston. They also have a wealth of information and background in viruses, vaccinations, and epidemics. So we're very fortunate to have them here. For those of you that have been at the past presentations, this information is all new, so there won't be much repetition at all. So we're really thankful for them to getting us up to date on COVID. And so now I'd like to turn it over to Drs. McCormick and Fisher-Hoch for their presentation, Quo Vadis, Variants, Sick Kids, Vaccines, and the Unvaccinated.
Thank you, Dr. Helsher. It's our pleasure to once again provide you with, we hope, the latest information, some of it actually from yesterday, on the ever-changing landscape of COVID-19, both in Texas and in the United States. Our program, our presentation will provide you with the information on the things that we summarize and a few other things that have come about even since we sent the summary. As you know, this changes literally daily. So without further ado, let us get started. Let me get us over to our, and I hope everyone can see the full screen. Are you able to see the full screen? So the presentation that we're going to make, let me go to the next slide. Yeah, go to the next slide. First of all, we want to show you where the hotspots are. It won't surprise any of you who keep up with what's going on that the states in the southern part, southeastern part of the country are the ones that with the hot spots at the moment. That includes Texas, Louisiana, Mississippi, Alabama, Georgia, and of course Florida, which is, and to a large degree, Tennessee. All states that have relatively low vaccination rates and therefore huge surges in new cases, often resulting in hospitals that are beyond capacity. And this shows you the winter surge that occurred earlier, and you can see that the winter surge is very similar to what we're seeing now, with ICU capacities overwhelmed now in this current surge. This graphic simply shows you the deaths that have been occurring with the compared to the winter peak. You can see this large peak here is the winter peak, and now you can see what's happening with hospital admissions in this current surge. And you can see that we're reaching, in some cases we've surpassed in some states. This is overall in the United States, but in some cases, hospital admissions, cases, and even deaths are surpassing, for some states, what they saw in the winter peak. But you can see that overall we're reaching toward the peak of last winter in January. And this particular graphic shows you the areas where some of the worst cases are occurring. And if you look over here to the right, you can see that in the Northeast, the peaks are not nearly as high. In the Midwest, but in the South, you can see here in this blue line, the considerable surge in cases in the South, as I've already outlined. And here's an example in Mississippi where it's actually now past the peak of the winter. So that's kind of where we are with the surge, and now we're going to describe some of the things that are involved in this surge and why it's coming so rapidly. So Dr. Fisher-Hoch will talk about the new variants of SARS-CoV-2.
So at this point, we need to be quite clear. This is a pandemic of the unvaccinated. And I think we're seeing that very markedly in the graphs and the pictures that you've just seen. Now, there are two things that are driving this. One, of course, is the lack of vaccination, because we have good vaccines available and a large number of people have been vaccinated. But the other is the issue of variants of the original SARS-CoV-2 virus. The one that emerged from China last year was a strain which is not even on this map because it has already disappeared. And then variants have come up. They're called two things: variants of concern by the WHO and variants of interest by the WHO. The ones that are really interesting to us now and are very concerning are the variants of concern. First of all, we have the Alpha variant, and the Alpha variant emerged in the UK. And it was a problem because clearly the viral load in people infected with the Alpha variant was higher than with the original variant. This meant that it was more infectious and therefore spread more rapidly. The Beta variant was of South Africa, and the Gamma variant was from Brazil. They have not really penetrated, but the Delta variant is the one that's really hit us now. That variant actually emerged from India. And this is an example of where you've got a large population that's unvaccinated. The virus can wreak havoc, and it can mutate, and it can change to something more beneficial to itself. So mainly, we are going to talk about the Delta. And the Delta is more infectious even than the Alpha, and we think it's probably more severe. So what is the Delta? Well, here on the left and the right are artists' impressions of the spike protein. The spike protein is the thing that sticks on the outside of the coronavirus and makes it look a little bit like a crown, which is why it's called coronavirus. And here you see marked the B167 variant, and this is the one that is the Delta agent. And the 167 refers to places where the virus has been able to change its amino acid on the surface. That is, it changes the shape of the spike that actually presents itself to your immune system. And this one is therefore, it has more than one variant, and therefore that has seemed to allow it not just to be more infectious, probably more severe, and probably starts to escape some kind of vaccine. And it hasn't stopped there, because it's also mutated a little bit to the Kappa on the right-hand side, which has yet another mutation. So this is not a static picture. We don't stop anywhere with these variants. That is, the virus doesn't stop. The virus is there to outwit us at every step. And the virus is very adept at doing this. So we have to have all our armament in place. So the replication and transmission of the virus in China was very interesting. I'll pass this over to Dr. Fisher, Dr. McCormick.
So one of the first reports of the Delta variant, in fact, just like the original virus, came from mainland China. And in this case, they were able to trace 167 infections in a specific area of China that could be traced back to what's called an index case. That is the first case. And from that case, then it spread out to others, ultimately resulting in 167 infections that were. And so what they did was to do daily PCR. You know, PCR is the test that everybody is familiar with now because that's the test that looks for the virus, whether it's the alpha or the delta or any other of the variants. That's the test that's used. So they did daily PCR of a series of quarantined subjects. And what they found was that the viral loads, that is how much virus did they detect in the nasal swab that was taken for the PCR. When did they first become positive? And what they found, now these are unvaccinated people, of course. So what they found was, on an average, that this virus had 1,000 times greater viral load than the original alpha, the B alpha lineage during the initial epidemic wave in China in early 2020. And they found that this occurred by day 4 after infection. And what this obviously showed was not only faster viral replication, but a higher viral load and greater infectiousness. So if you have more virus, you have a greater chance of transmitting it. And so that explains to a large degree why we're seeing this incredible surge with this Delta variant. It replicates faster, it makes more virus, and therefore can transmit more easily.
This slide shows that the actual relative transmission of this virus compared with other infectious diseases. And you can see the blue block in the middle, which is the SARS-CoV variant. It's round about the infectiousness of chickenpox, which is down at the bottom. It's not quite as infectious as measles, but it's getting there. But it's much more infectious than the ones on the right-hand side. The left-hand side, the ancestral strain, the original SARS, and a lot of other infections that we know. And I'd just like to make a little comment here. I'll just bring it back. There's been a viral video. There's a lot of misinformation around, and some of it's kind of dramatic and picked up by certain news agencies who ought to know better. This viral video says that, in fact, it is not spread as much, and this is, in fact, incorrect. And they also say it is supported by an animal reservoir. It's not. It may infect animals, but there's been no evidence that it goes to animals and back to humans. This is a human-to-human virus.
And just a further comment, this viral video does suggest that we can't get rid of the virus because it's supported by an animal reservoir. Well, the animal reservoir that has been identified thus far is a bat cave in southwestern China. It's clear that the global population is not exposed to bats from southwest China.
Particularly these bats.
Particularly these bats. So the idea that this somehow is supported by an animal reservoir just doesn't add up.
No, that's not the case.
So the Delta variant may cause more severe disease than the alpha or ancestral strains. And some published evidence come from several different places. In Canada, they looked at higher odds of hospitalization. This is just a measure of the increased chance of hospitalization from this Delta variant. And what they found, it's almost a twofold increase, 2 or 2.5-fold increase in chances of people going to hospital or the ICU or dying from this particular variant. And that was found in Canada. It was also found in Singapore, where they did a similar study, and they looked at oxygen requirement, ICU admission or death, and pneumonia, and found again anywhere from a 2 to 4-fold or more chance of these occurrences in people who who were infected by the Delta variant compared to the previous. And that similarly, higher odds of hospitalization were found, almost 2-fold in Scotland. So this strongly suggests that not only is Delta more contagious, but it causes more severe disease than the previous strains.
And it also causes more severe disease in younger people. So the people we're now seeing in hospital tend to be a mean age of in the 40s instead of in their 70s. And it is definitely pathogenic in children. We'll come to that later and discuss that. But this particular variant is obviously able to cause severe disease and even death in young people and in children. So the vaccines now. Here's a list of the vaccines Dr. McCormick will discuss.
So you're all familiar now with Pfizer, Moderna vaccines and the Johnson & Johnson vaccine that are here in the United States. But there are many others from Russia, for the AstraZeneca vaccine from the United Kingdom, the Chinese vaccine, CanSino. There's another vaccine called from the Vector Institute in Russia. Some of these are quite similar, in fact, to the AstraZeneca and the Johnson & Johnson vaccine, in that they use an adenovirus vector to get the mRNA into the cells, whereas the Pfizer and Moderna, as most of you are familiar with now, use really it's not new technology, but it's new to vaccines, and that is using messenger RNA as a primary vaccine. And that's what the Pfizer and Moderna do, and they are highly effective. For the original strain, they were extremely effective, over 90%. There are a whole string of other vaccines. You can find this list. I won't go into all of them, but they're from various parts, particularly from China, Russia, Europe, as primary manufacturers of vaccines.
Just a comment about the Chinese and the Russian vaccines. The Russian vaccine looks a bit like the AstraZeneca vaccine, but the Russians aren't releasing any data, so we really can't be clear, but it looks to be okay. Chinese vaccine is a whole inactivated virus, and the data there are very, very shaky. It does look as though its protection is very poor. But if you go to the top of the list, the mRNA vaccines, the Pfizer and the Moderna, are really extraordinary. They're extraordinary both in their efficacy, how much they protect, and also in their safety, with very, very minimal side effects.
So again, the hotspots are here, and you can compare the maps here on the hotspots with vaccination maps, and you can see that some of the lowest levels of vaccination are in the southeast, where the hotspots are. And globally, you can see there are also hotspots that include the United States, some parts of South America, and a number of places in Asia. Africa is a continent that has really limited surveillance and reporting, and so it's extremely difficult to know exactly what's going on there, except the reports seem to show a high number of cases. And of course, Brazil has been one of the real hotspots of the pandemic. And even though the Brazilians are starting to get vaccine, unfortunately, they initially used the Chinese vaccine that is not very effective. I think that's been one of the reasons that they've not seen much of an impact on their pandemic.
But you'll see it doesn't match exactly, and we'll talk about that later. There are reasons for that. So here is an illustration of why you need to get vaccinated. On the left-hand side, there's some data from the San Diego COVID-19 hospitalizations. This is dramatic. Fully vaccinated, hardly anybody. Not fully vaccinated, most of the people were sick. And then here on the right-hand side, you will see in Los Angeles County, the unvaccinated are the ones who are most affected by the virus. And the hospitalization is age-adjusted 70-day hospitalization rates, once again, dramatically. This is a pandemic that we have to vaccinate. Once again, we've been hit with information from viral videos, which assert falsely that vaccines do not protect against the SARS-CoV-2. If you look at this particular slide, you've got to start laughing, say, well, you know, were these people awake? Have they ever looked at any real data? Do they actually know what's going on around them? In addition, they've also stated that antibody-enhanced mediated enhancement. Now, this is a weird thing that you may not have heard of, mostly associated with dengue virus, never with any other viruses. After 50 years of study, it's never been really improved. And they say, oh, the vaccine enhances the COVID. So that you've got the vaccine, you're going to be much sicker. Well, take a look at the green column and take a look at the red column and see whether you believe that.
This is
crap. This is really crazy.
Yeah, this is an idea that somehow when you create the antibody, it helps the virus get into cells and create more severe illness. And if that were the case, it would reverse these two graphics, and it doesn't. So the idea that this doesn't protect against this virus and its disease is complete nonsense.
And on the right-hand side, you can see that the hospitalizations go exactly the same way in yet another place. So what is the story? Here is the sort of story that we're all hearing about. She got the shot and he didn't, and these are the consequences. Both of these people spurned the vaccine, and they would like you to know that they now regret it. So many cases of patients just about to be intubated saying, nurse, can I please have the vaccine? Without understanding, the vaccine is not a treatment, it's a prevention. And once you're sick like that, the vaccine won't do anything for you. Not only that, what you will get is hospital bills of upwards of $40,000 these days. And here, even pregnancy, it's clear that vaccination in pregnancy is highly beneficial and safe, and that COVID in pregnancy is very, very dangerous. And here we have the other side of this, is that we are hearing more and more about patients with non-COVID diseases not being able to get into ICU when they need it because it's full of COVID. So the vaccinated are now suffering because they can't actually get into hospitals because it's full of the unvaccinated with COVID. The other thing that is also happening is rather distressing, is very large numbers of nurses and healthcare personnel are resigning because they've just got too much burnout, too much distress with young people dying.
Comment. The bottom here shows you also another side of this. And this was a man who said, my 16-year-old son was lucky to get a pediatric ICU bed when he needed one. He shouldn't have needed luck. Well, this is occurring because even in the pediatric hospitals, ICU beds are, in many areas, are completely full. In fact, beyond capacity.
About half of them are COVID patients. So,
yeah, there also was an implication that somehow vaccination of people after prior COVID disease was not effective. Well, this study was funded by the National Institute of Health, two different institutes within the National Institute of Health. This was published in Nature Medicine, a very highly prestigious, highly cited journal in the United States. More than 1,000 people at Cedars-Sinai Hospital in New York received 2 doses of the vaccine at the time of the study. Those previously infected with SARS-CoV-2 had higher levels of antibody at all 3 time points, which tells you that having had COVID is a clear indication for also being vaccinated, and it gives you even higher levels of vaccine of antibody than just with the 2. The levels of antibody taken before vaccination in people who were previously infected by the virus were similar to those seen in uninfected people after their first shot. So this just shows you that it is very advantageous to get a vaccine, even if you've been infected with COVID. Antibody levels, the researchers used 2 different tests to see whether antibodies in people's blood had the potential to neutralize the virus. After a single vaccine dose, antibodies from previously infected people performed similar to those from uninfected people after 2 doses. So the infection actually acted also as a, if you will, a vaccine. That's exactly what we would expect because the immune system saw the virus and made antibody to it. Overall, individuals who were previously infected with COVID developed an antibody response after a single vaccine dose, comparable to that seen after 2 doses. So it appears that a single booster dose given to previously infected individuals offers the same benefit as 2 doses given to people without prior infection.
And just as to add to that, there was a story yesterday about a personal trainer in incredibly good health, fit and very, very muscular, who got COVID. And so he said, I don't need the vaccine, I've had COVID. So he got COVID. He ended up in the ICU, he ended up ventilated, and he lost 70 pounds and is now dependent on nasal oxygen. So there is no escape from this. The other explanation for those of you interested, why should this happen? Well, many viruses, and this is one of them, have particular proteins. All viruses make a lot of different proteins. And the COVID virus is able to make a protein that actually turns off your immune response within the cell. And the Delta variant seems to be even better at this, at turning off your immune response to the virus. Then after a while, the cells say, just a minute, I'm being invaded. And then they overreact, which is why you get the very, very big syndrome where you really can't breathe and you have all sorts of cardiac and other complications. The advantage of the vaccine is that it only contains the part of the virus on the outside and none of those internal proteins. So it really has got a big advantage over that for infection in terms of protection. But here is yet another viral video.
Yeah, this viral video, again, falsely asserts having prior infection did not result in a vaccine response. Well, that's not true. You can see from this study that even if you've had a prior infection, and from the case that Dr. Fisher-Hoch just described, you can get infected again. So that is a reason for people to get, even if they had prior COVID infection, they should go ahead and get vaccinated because it will protect them against severe disease from this particular variant.
And even death. And this is where this kind of information circulating is not only dangerous and incorrect, but it's actually responsible for deaths. So there is a greater risk of disease, hospitalization, and death among the unvaccinated versus the vaccinated people. There you can see the green are the unvaccinated and the blue are the vaccinated. And you can see in every category.
Disease, hospitalization, and death. The green is hugely bigger than the blue.
So anyway, the mantra here is get the vaccine, get the vaccine, get the vaccine. If you want to survive and have the people around you survive. So here are the data about booster doses. So now the question has come up, are the 2 doses sufficient for the single J&J? And the question has been in the air since about June when Pfizer started to recommend booster doses and the FDA said, no, wait a minute, not yet. So where are we? Well, Israel is an interesting experiment. Israel acquired the Pfizer vaccine very, very early on. In fact, there was a big controversy in Europe, some of you may remember, because Israel bought so many doses when there was still a shortage. But Pfizer responded by saying, well, Israel paid us market price. And at that time, the EU was trying to get it on the cheap. So Israel paid the market price, got the vaccine, and vaccinated as many people as they possibly could, and really dealt with the epidemic in Israel. So 78% of the elderly in Israel have received 2 doses of the Pfizer vaccine by February 2021, very efficient. Consequently, all preventive measures were lifted as well back to normal. So what happened now is in the last month, they experienced a Delta variant surge. And the surge is as bad as the one they had last December. So what's going on? So more severe disease was seen in the elderly who were vaccinated early. So this suggests that there is some waning of immunity. And having seen that information, very recently, booster doses are now being recommended here in the US at 6 months post 8 months past the second dose, which is about where we are right now. So that's why the date of September the 20th came out, which is about 8 months after the initial vaccination campaign in this country.
We know that the elderly do often respond less well to vaccines. That's true. That's why there's a high-dose vaccine of flu for the elderly and high-dose and double-dose vaccines for pneumonia for the elderly, and because they do risk waning immunity, and that's probably what we're seeing now. So for those, even for those few people who are hospitalized that are fully vaccinated, they tend to be, even among the elderly, people particularly with underlying conditions like obesity, diabetes, renal disease or heart disease, or people who are immunosuppressed with autoimmune disease or being treated for cancer.
And recently we just heard of one case who's really ill in hospital, who's vaccinated with severe alcohol and drug abuse problems.
Right.
So anything that predisposes you to severe disease, it is going to undermine the immunity from the vaccine. So we're probably getting into a territory here that the decision hasn't been made for probably regular shots with these viruses, these vaccines. So the dose effect, the vaccine, second dose effectiveness for Alpha versus Delta is really dramatic. Here are data from England, Scotland, Canada, and Israel. If you have the green dots of the Alpha variant and the triangle of the Delta variant, now you will see how much more dangerous the Delta variant is. The confirmed infection and symptomatic disease and hospitalization are increased. The effectiveness is better in the Alpha variant than the Delta variant, which escapes.
The good news is that, as you can see, this is confirmed infection, and there is a fair difference. There are many, and that's why we're seeing more infections in people who are fully vaccinated. But when you get to symptomatic disease and hospitalization, there's not much difference. And so that tells you, and that was true for England and Scotland, Canada and Israel. You see the difference is even bigger in Israel, where the prevention of confirmed infection or symptomatic disease dropped pretty dramatically, but hospitalization and death were almost equal, which means that the vaccines are really protecting people against severe disease. Not always against symptomatic disease or infection, but really effective against severe disease.
So now we're going to see actually what the booster does, and that's going to be interesting. So once again, these viral videos are saying that vaccine does not stop infection. Well, here you can see that it clearly does. So this is dangerous information. So who's not vaccinated? Well, who are the people who are not vaccinated? And they are usually from lower socioeconomic status, and where they have low household incomes, they have children in the household, they have food insecurity, fearing eviction, and also occupations that are associated with possible infection. Now, these are the people who are, we might call hesitant, but they really have had difficulty accessing the vaccine. So the unvaccinated are divided into two categories. There are those who really have had trouble getting the vaccine, probably to a certain extent through no fault of their own. There are a lot of efforts being made to help these people. The other are the vaccine refusers. They're not hesitant. They're just obdurate. And those people, we really don't know what to do. But these people are actually threatening the rest of the population, like holding essentially a loaded gun pointed at them, because they will stop us getting control of the epidemic. So how are the states doing? These interesting bubbles are showing you at what point in 2021 or in 2022 we'll manage to get to 70% of adults. And you see the Northeast is doing very well. We're in Colorado right now, that's doing okay. Texas down here, now we come to the South. And then we get right down into the places with a lot of problems. West Virginia, by the way, isn't even shown on this slide because it's off the map. because it only achieved 70% in late October 2022, and there wasn't enough space down here to show it. So the differences in achieving what ought to be herd immunity is very much slower in some states than others. And the problem here is we're no longer sure that 70% is adequate.
Yes,
We
that's
think
right.
it's going to be more like 90%.
Yeah, it's looking like the so-called herd immunity for this new variant is much higher than 70%. And so that pushes us even more. So can we create a universal vaccine for all COVID-10 variants? There is research in progress to do this. And we've already suggested that the current vaccines will likely are going to require boosters, but there are new vaccines using the newer variants that are also on the horizon. As we learn more about the spike proteins and what are called the highly conserved regions, that is, these are spaces on the spike protein that cannot mutate otherwise the virus is not viable. And so we need to learn more about those, because using those in a more effective way in vaccines might create a more universal vaccine. And that's the kind of research that's ongoing right now. So the researchers are using all kinds of modern technology to be able to try to identify these sites and then try to make vaccines, candidate vaccines, that would use this new information for more effective vaccines. Now, there is a report, again, in Nature magazine, a very highly cited scientific journal, that have uncovered what they're calling a super antibody. And the reason they call it that is because it seems to protect in the laboratory against all manner of these viruses, not only SARS-CoV-2, but the original SARS vaccine and many of the other viruses that are in this group of the so-called SARS-CoV viruses. This is the larger family of coronaviruses. So this is a fairly recent publication, and it may be, in fact, that is the kind of site that is needed that we need to understand, that may, in fact, be one that is conserved. That is, the virus can't change it and still be viable, and yet we can make antibodies to it that would prevent the virus from infecting us. So this is an exciting area. We'll see where it goes. Right now, we haven't. We're not quite there, but it's certainly an important. Here's just a little cartoon that shows you the concept of these antibodies that are in blue, and then it's harder to see the spike proteins in purple. But the idea is to get as many antibodies to these spike proteins as possible. And also, I just wanted to illustrate to you on the left-hand side, lower left, where my arrow is here, look at the global nature of research nowadays. Here we're looking at Seattle, Washington, San Francisco, Washington University in St. Louis, Sloan Kettering, Weill Cornell, Leuven, Belgium, and Cambridge in the UK. Those people all collaborated to create this new research on the super antibody.
So treatment. Monoclonal antibodies, you've heard about the infusion that people get, particularly if you're well connected politically, you will tend to get the infusion. And they're monoclonal antibodies, and they were pretty good in the early years, as long as they're given early in disease. They have to be given really about onset of disease, otherwise they don't work. Two of these are already sidelined, and this is because the Delta variant has escaped these particular monoclonal antibodies. Now, the monoclonal antibodies only stick to a particular part of the spike, unlike the vaccines, which express the entire spike. So the vaccines have not been subjected to this kind of sidelining, right, the way that the monoclonal antibodies in. So only 2 are currently generally recommended. They are being used. Again, if you're politically well connected, you'll get them. Regenerons, azirimumab, they're all difficult to pronounce. GlaxoSmithKline and the biotechnology ones are being used.
There is a viral video out there that asserts that ivermectin, which is a treatment for parasites in cows and horses,
Worms and things.
Worms, and zinc and 25-hydroxyvitamin D prevent infection. That has 0 credibility at this point. I searched high and low, and there may be some ongoing studies, but there is no credible evidence that these work.
The problem is that people are listening to this stuff, taking this stuff, and they're highly toxic, and they're ending up in poison centers, particularly in Mississippi and Alabama. So these things, these drugs, these veterinary drugs, are highly toxic if they're taken in large quantities and can cause a lot of damage. So mitigation, let's have a look at this, because this is really very interesting. Because here we have the number of infections that you actually get, COVID-like disease, loss of taste and smell, and test positive, depending on the mitigation measures you use. Now, the more you use, the less infection and the less consequences you get. So the more mitigation measures you use, the better you are off. However, there are some, such as masking of students, teacher masking, now we're talking about schools, restricted entry to schools, extra space in the schools, no supply sharing in schools, getting the same students together, not mixing them, reduced class size, and daily symptom screening are effective in reducing the number of infections and transmissions. Same teacher is helpful. However, what is not helpful, interesting, are the desk shields, the plastic shields, that's here, apparently do not really help. And that includes the ones that you put over your face, because what it does, it reduces airflow and causes stagnation of air in certain places, allowing the virus to concentrate in large quantities. So household COVID-19 risk and personal schooling, here are the same sort of data. Masking, teacher masking, restricted entry, and so on, all of them, you see quite clearly, reduce the transmission in the schools. Now here are masks. It has also been said that masks don't work. Masks do work, but it depends on the mask. And here we have different kinds of masks at this side, and the N95 and the surgical masks, they're very good. And then you come to a series of masks, including cotton masks, as long as they're 3-ply, are also very good. But you come up here where people are using bandanas and knitted masks, they don't work at all. So the masks work, but the type of mask is very, very useful. Here you'll see no mask at all, that's the amount of infection. Red, bandanas, they don't work. Orange, cotton, and blue, surgical at the bottom. But here is the thing. There's a viral video. This viral video says that masks don't count. They do count. And they do not, in fact, transmit any other kind of disease. If you have the cotton masks, you can wash them in detergent and you're absolutely fine. And the masks actually work very well. But do make sure if you have a cotton mask, it's 3-ply and that it fits properly around your face. So COVID-19 in children, you want to take this one?
So hospitals, this graphic just simply shows you what we've already alluded to. Look at January 2021 for hospitalization of children in the United States. And now look over here at July 2021. And you can see we're already at or nearly above the surge in children back in the winter.
But this is all caused. So these children will not necessarily have COVID, but these kids have got COVID.
Yeah.
Now, the other thing that is happening in children is you may have heard of the long COVID syndrome. The long COVID syndrome occurs in up to 30% of people, but it seems to be relatively common in children. And these are symptoms which, even though they recover from COVID, tend to persist for days, weeks, sometimes months, sometimes even longer. Particularly fatigue, you see how many days it lasts. Loss of smell lasts a long time. Headaches last a long time. Sore throats last quite a long time. So the risk for the kids is not just hospitalization, it's also involved in the long COVID syndrome, which of course is a disability for children because they can't take part in their usual activities and their usual developmental processes. So there are reasons for getting a vaccine. I'll go through these and give the next slide to Dr. McCormick. What are the reasons? Personal reasons or community reasons. One is to avoid getting sick, obviously, and to avoid being hospitalized. To avoid ending up in intensive care, intubated, and avoid dying. Now, all those sound like pretty good reasons. To avoid the long COVID syndrome, which can be very disabling. If you're pregnant, to protect the mother from severe, possibly fatal disease, and you protect the baby, which could be lost. There are community advantages. Getting vaccinated is more than a personal issue, and it's not a question of opinion or anything like that. It's a question of community responsibility. You have a responsibility of community not to get infected. You need to spare overworked, stressed nurses, medical staff, who then have to look after you. Limit your ability to spread the disease. Protect your community, protect your family, protect your worst case. To help control and limit this deadly pandemic, that is very much a personal responsibility of everybody.
So what the vaccine does not do is that it doesn't implant a chip in anybody.
Or make you magnetic.
Or, right. It doesn't, it doesn't make you magnetic. It has no effect on fertility for men or women. It does not lead to so-called enhancement, as we said earlier. Seasonality only affects certain respiratory viruses, not the coronaviruses. So that's not true. It cannot possibly cause COVID because it only contains a part of the virus. And it does not cause COVID, so obviously. And so SARS-type coronavirus pandemics depend on human behavior. And the induction of enhancement of subsequent infection does not occur. So all of these are myths that need to be debunked.
Now, a topic that's come up recently is where did this thing come from? So there are two particular hypotheses. One that it was a natural source, it jumped from bats, and the other one that it escaped from a laboratory. So this virus is a beta coronavirus, and it comes from horseshoe bats in South China. So the original SARS virus was a beta coronavirus and probably passed through palm civets. They are a delicacy and traded live in the Wuhan wet market. So that's how the original SARS probably got there. The first SARS cases were in the wet market in Wuhan. There's no intermediate host for SARS-CoV-2, which is absolutely required because this virus is not the same as the bat virus, which has changed. The virus is a modified version. The horseshoe bat lives in caves many thousands of miles from Wuhan, not eaten or traded by food, and cannot fly that far. Unlike SARS, none of the original cases of SARS-CoV-2 were from the wet market, but from different parts of a very large city. So the other evidence is getting more complicated. The Wuhan laboratory was working on horseshoe bat virus, isolated from bats they captured in the South China. They went down to the cave, captured some bats, and got the virus. The original SARS virus was a beta coronavirus. An intermediate host has been identified for SARS-CoV-2. The virus is a modified version of the horseshoe bat virus, so it does require intermediate hosts, and it's many thousands of miles away. The Wuhan laboratory is a recipient of an NIH grant to study gain in function. I must explain this to you. These experiments means that viruses are manipulated genetically in the laboratory to see whether they can be made more pathogenic for humans. The idea is to understand what might happen, and so that you can probably prevent it happening. This process is very controversial, but this is the work they were doing in Wuhan. The SARS-CoV-2 has genetic coding not found naturally in bats. It's got a human code in it for an important amino acid which affects binding of the virus to human cells. This is hard, it's high-level molecular virology, but it's really very telling regards on evidence. There was a rumor of a respiratory outbreak at the Wuhan laboratory in November 2019, requiring hospitalization of young people. However, the Chinese have destroyed, suppressed all laboratory data on all data associated with the possible 2019 outbreak, closed the wet market, destroyed all animals, etc. So the data have really been suppressed by the Chinese. And there has been silence from the US virology community. The Chinese are currently spreading a wildly misinformation that the virus will escape from Fort Detrick. So we're in heavy-duty political territory here. And you have to draw your own conclusions.
So let me just summarize very quickly. I can only say vaccinate, vaccinate, and mask, and mask. That's really the key issue, even today, and it has been for quite some time. And 90% of hospitalizations from COVID are in unvaccinated people, and that's from the Delta variant that we have shown to be shown you the data that show that it's much more contagious and much more severe. Vaccinated people can be infected and they can transmit the virus, although they don't do that nearly as effectively as unvaccinated people. They also harbor the virus for shorter periods, and although they're mostly asymptomatic, not always, and they can have mild symptoms. And as you saw, there are some people fully vaccinated with severe underlying conditions that end up in hospital, rarely dying. Have younger vaccinated people are now being hospitalized. You saw that information. And immunity may be waning 8 months after full vaccination, especially in the elderly, necessitating a booster. So with that, we'll stop and take some questions.
So thank you for that excellent presentation. A lot of information, very relevant today. So as usual, we have a lot of questions, so I'll kind of jump in. So the first one is, why are children's hospital data not reported out similar to adults? It would provide a clear, authorized source of information that parents could use to make decisions on their children's safety and advocacy.
So typically, all of the cases are aggregated, just regardless of age. That's what we see. It's not that that children are not being reported; they're just all aggregated together as cases of COVID. And you have to go to specific sites that are tracking. And I think the Hopkins site is starting to track.
To do that.
Yeah.
They're starting to do that
They're
now.
starting to do that now more, but in the past we didn't have that many. Nowadays we have obviously many more, and so that's starting to be a much more targeted area. And if you go to some specific sites, you'll find more information.
Great. How are variants being tracked in the U.S. when many times you just receiving test results takes a week and a positive test doesn't necessarily capture the variant information?
Well, a positive test shouldn't take as long as a week. You know, it really is. It should be a 24-hour turnaround. But unfortunately, it just tells you whether you've got the virus or not. It doesn't tell you about the variant. There are tests for the variants, specific tests for variants. They're very expensive, and only a few labs do them. The real answer to this is you have to sequence the virus, and that is very specialized as far as the lab's concerned and very difficult to do. We're starting to do a lot more sequencing. It was not done early on, which is why we missed the appearance of variants. You know, last summer we didn't really see the alpha variant emerging because the sequencing was only being done in a few places, but now people are starting to sequence.
So there also now are emerging some PCR tests that are specific for the Delta variant. Unfortunately, they are not part of the so-called CLIA-approved diagnostic laboratory, they're research. We do it in our laboratory as a research tool and have shown that we have lots of Delta, that most of our viruses now are Delta variant.
But right now, you can assume about 90% of the cases are Delta.
Yeah.
Great. So why are we having more breakthrough cases this time? What about data for those who have had COVID already and aren't vaccinated?
It's the virulence of the Delta variant doing this to us. Look at Israel. You see, that is exactly what they are documenting. We have to be thankful to Israel for getting onto the ball very quickly and for documenting it to make their data available. It's clear that there is waning immunity and that the elderly are particularly at risk.
I can't emphasize more, however. Yes, there are breakthrough infections, but look at the data we showed. Hospitalizations, ICU, and death are all almost exclusively, way over 90% in the unvaccinated people. So there should be no idea that, oh, we've got breakthroughs, so vaccines don't work. That's just not the case.
So here's a question about the vaccines. I've received the Moderna vaccine. Can I get the Pfizer booster shot, or do I need to wait for a Moderna booster?
No, these two vaccines are pretty well the same.
You don't need to wait.
No.
In fact, I think you could even, my personal view is you could get any one of the three vaccines as a booster, and they would all be quite effective.
They all do the same
They
thing.
do the same thing.
Good. So here's the question. I find that a portion of people who are fully vaccinated feel it is unnecessary for them to wear masks when they are at indoor gatherings. Am I correct that they are just as susceptible to catching COVID as unvaccinated people, although their chances of having to be admitted to a hospital and dying are much less? And if I'm correct, why is there not much more emphasis not given to stressing that all people need to wear masks?
But this is changing. They are not as likely to get infected as the unvaccinated. We've already shown that. They have lower viral loads and they're less likely, in fact, to get infected. However, we as fully vaccinated people have decided in the last month, we're going to go back to wearing masks whenever we are indoors because the situation has changed. And I think now, from now on, that the vaccinated should consider using masks in indoor settings because of the additional risk from the Delta agent.
And the fact that it is possible for them to get infected and transmit to someone else. So yes, we think that everyone should be, when they're indoors with people they don't know whether they're vaccinated, not vaccinated, especially, should wear masks. We do it for whenever we go indoors.
This brings us to the point that people complain that the advice is confusing. Well, the epidemic is confusing. And we have to keep track of it, and then we have to change our advice and our behavior according to what's going on now, not what happened 3 months ago. So it is very important to keep up to date and to make sure that you're doing the right thing for this moment and not for 6 months ago.
Well, you did a very good job of answering the next question I was going to ask you about the conflicting advice. So thanks for thinking about that ahead of time.
Yeah,
so
we all get conflicted because it moves so fast.
You know, I think I want to make a point about the CDC and the National Institute of Health. They have thousands of scientists. It is inconceivable that somebody is going to muzzle all of those scientists into a large kind of cabal of misinformation. It's just nonsense. The misinformation is coming from people who think they are experts, not from the people whose lives and whose profession it is to produce the information that we showed you today.
That's the difference between having an opinion and actually knowing what you're talking about.
And that's, I think, a very good way to end. We're at time right now. So I'd like to thank Drs. Fisher-Hoch and McCormick once again for a really excellent webinar. And I'd like to thank everyone in the audience for attending today's webinar. Remember, this will be archived at our website at msdcenter.org. Thanks again for joining us. Stay safe, and we'll see you next time. Thanks again, Joe and Sue.
Our pleasure.
Our pleasure.
Bye-bye.
Bye.